We want to thank NOAA Medical for being 2024 SAB sponsors and for their continued support. I'm going to hand it off to Dr. Hussam Naif now, as he's tonight's moderator. He sits on the SAB's Education and Program Committee and is also the Chair of Industry Relations. Dr. Naif.
Thank you, Emily. Welcome everyone to the Society of Advanced Bronchoscopy webinar series. Your host today, Hussam Naif. We present to you discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today we have an exciting topic, diagnostic confidence, success, insight. So we have Dr. Joseph Cicenia, who currently works at Cleveland Clinic and has nearly 20 years of experience. He has authored many articles in peer-reviewed journals and is often a key speaker at conferences. He has extensive experience with a variety of advanced navigational solutions, including Monarch, Ion, Body Vision, Illumisight, and now Galaxy. We have Dr. Bobby Mahajan, who has been the System Chief of Interventional Pulmonology at Inova Fairfax Hospital and oversees Inova's Incidental Lung Nodule Program and Lung Cancer Screening Program also. He has been involved in a number of studies, including Benefit, Navigate, and Match. He was awarded the Presidential Service Award for his working during COVID-19 and for his work with the American Lung Association. Without further ado, our speakers, Dr. Joseph Cicenia, go ahead.
All right, let me show my screen. You guys can see this, I'm assuming?
Yes, you're good to go, yep.
Okay, great. So yeah, I'll be this first speaker tonight. These are just my disclosures. So look, just a little brief history, right, of why the challenges of going after nodules. In the past, before we had any sort of navigation, there was difficulty in accessing these nodules, first getting scopes to where the nodules were, seeing them on fluoro, and even when you see them on fluoro, 2D fluoro has its limitations, right? So the whole idea of developing navigation was to take a catheter or take something to deliver your biopsy tool to the actual location where the nodule was, that used the capabilities of both fluoroscopy and other technologies to kind of leveraging these technologies to kind of target and locate your nodules. This is what led to the original inception of electromagnetic bronchoscopy. However, when we look at the history of navigational bronchoscopy, starting in the original study published by Tom Gilday at the Cleveland Clinic before I got there, you could see that up until 2018, when Eric Folk did the landmark Navigate trial, that yield wasn't really incredibly robust. We had yields somewhere between 60 and 74%, and a lot of these yields were more or less a little bit lower than what you see here based on our current strict definitions of yield. These are kind of more liberal diagnostic type of yields. But even when we came out with robotic bronchoscopy, the yields didn't really change much. They really didn't go up. A lot of people were expecting robotic yields to go up into the 80s, 90%. But when the first generations of these robotic platforms came out, they really didn't achieve much better success than the navigational modalities that were used just with plain old plastic catheters. I mean, obviously everybody remembers the plastic catheter and how its deformability really limited what you could do in terms of diagnostic approaches. So even if you could get to the lesion, the diagnostic tools, which are more or less rigid, could literally move your catheter out of position, making things very, very difficult. If anybody was practicing back then, they could feel the pain of that happening in the lower panel. So the other issue that we also tended to understood as we went along was, well, perhaps it's not just the catheter that is the issue. Maybe it's actually this concept of CT body divergence. Maybe the target that we were navigating to wasn't exactly the target to begin with. And sometimes initially when the target was large enough that you could see on fluoroscopy, you could actually see this, right? The EM guidance was taking you to one place, but you could clearly see that the nodule was kind of shifted over to the other side, perhaps of where your catheter was. And this CT body divergence was really highlighted by the original work of Mike Pritchett, who did really seminal work down in North Carolina with his cone beam CT. And what he noticed that using cone beam, that the actual location of the nodule wasn't exactly where the CAT scan done a day or two or a week before actually said it was. So he did a very elegant study where he took the CT scan and then compared it with his cone beam images, and he measured the distance between where the nodule should have been based on the CT and where the nodule was at the time of procedure. And he found that there was an average divergence of up to 12 millimeters in the upper lobes and close to 20 millimeters in the lower lobes, which is pretty significant. When you think about the type of nodules that we're biopsying are all in this kind of size range. This was pretty profound. You know, he sort of quantified what we all were kind of thinking at the time. The next study that he did was he said, well, how often does overlap happen? So a very similar study where he took a virtual target center, which is where the technology was telling you the lesion was, and then he compared it with the actual target center, which is where the cone beam was telling you it was at the time of procedure. And he kind of showed the percentage of overlap. And what he showed was in almost a third of nodules, there was no overlap at all. So what you're targeting didn't even have tumor in it or nodule in it. It was just targeting lung. In another third, there was only a 0 to 25% overlap. So in almost 2/3 of your patients, you had less than 25% overlap. So you're targeting where your tool was going might not have been where the nodule actually was. And if you look, and Bobby's going to talk about this more later, even if you look at all of the robotic studies that were done without imaging, all have yields that hover around 75, 80%. But the moment that you add in advanced imaging to help you target and localize, the yield suddenly goes up to 90%. So this kind of highlights, you know, the challenges that we kind of went through over time. We thought it was, well, you know, we can't see where we're going because fluoroscopy doesn't get us there. Let's create navigation. But the navigation didn't really fit the bill because the catheter was maybe not robust enough. But then we fixed that with a robotic scope that had structural stability. And even then, we weren't getting robust yields. And not until we added imaging on top of all those other advances did we finally get to where we needed to go. So with that in mind, let's talk a little bit about the Galaxy system, which is one of the newer robots that are out, which incorporates all of this technology into one platform. So not only is it a robotic scope, but it also leverages DT technology to help overcome CT body divergence. And it could do this either with 2D fluoro, or it could do it with 3D or cone beam CT type systems. So here's the Galaxy. I'll walk through the procedure with you very quickly. There's obviously a registration and navigation, a target location updating, and then targeting and AF. And we're going to talk about each one. Registration is done very simply. You just put the scope in and out of the airways to get your registration. And then a navigation is done just like you would with any other electromagnetic type of technology, where you drive down the airway, you follow a pink line, and it sort of gets you to where you sort of need to be, where the nodule is. Once you get into the vicinity of the nodule, then you'll do your target updating. And this is done doing a spin at isocenter, where the nodule is at isocenter. And if you're doing 2D fluoro, you'll do a 60-degree sweep. This 60-degree sweep will create imaging that gets placed into or sent over to the CPU of the system. The CPU of the system will then identify where the new target location is, and it will relate it to the tip of your scope. And you'll get an image that looks like this. You'll get a targeting. You'll get a targeting screen, which is that blue with the white ball with the crosshairs, and then you'll also get augmented fluoro. So wherever that target is with your ball will reflect with the blue circle on your fluoroscopy screen. So you'll have both. You'll be able to know where to send your robotic scope, so your dead center, and you'll be able to see the tool come out into exactly where that target center or where that nodule is using your augmented fluoro. If you so choose, when your tool goes out into the nodule, you could do another spin, you could do another tomo spin, and you could do reconstructions on that. And as you can see here, you could confirm that your tool is in lesion. So here's a small nodule that we did at our own site, and you can see a needle clearly sitting within that nodule. So the value props of the technology here are you visualize and navigate all the way out to the periphery using EM technology with always-on visualization. They solve for CT body divergence using DT and targeting. The augmented fluoroscopy, I think, is a really nice feature that it has, because a lot of times that you'll actually go out, you'll target, your tool will come out, but it'll deflect at the last minute for whatever reason. So having augmented fluor, I think, is super helpful. You could confirm tool and lesion very, very easily, all within one system. There's no walking around here, there, adding other technologies to get this. And then obviously there's precision with biopsying with small peripheral lesions using robotic stability. So what's the evidence behind this? Because we could talk all we want about these features, but how do the features in real life, how do they affect what we do and the outcomes of which we have? The first study that was done was really like, the original feasibility trial. This was done in Australia. It's called the Frontier study. This was 18 patients, 19 nodules. And you could see this is a very early version of the technology, probably version 1A. And they had 100% successful navigations. They had 100% of the time they were able to diagnose or demonstrate tool and lesion, and their diagnostic yield, was super high, between 89.5 and 94.7, depending on where those benign nodules would have turned out to be 6 months later. Not all of them obviously were malignant. Moving forward into more recent versions and larger patient cohorts, this is a presentation of that Abhi Agrawal's group. Abhi's out in New York City at Northwell Health in New Hyde Park. Abhi presented his first 60 patients, 67 nodules in 60 patients with an average size of about 22 millimeters. And he had a successful navigation in 100%, as we would expect, with the diagnostic yield somewhere between 88 and 93%, depending on where the follow-up studies will be on the, and this is done using strict definitions. With obviously very low complications, as you could see. We published our first cases, and I'll just skip through this really quick. We had 116 nodules. These are our first 100 patients. One was removed from the diagnostic yield analysis because it was a fiducial mark replacement. The average nodule size in our cohort was 12.9 millimeters with a median of 14. So our nodule sizes were smaller than what you'd normally expect in a study like this. 10% of our nodules were under 10 millimeters in size. 12% of our nodules were GGOs and 26% were part solid. So really, when you do the math here, about 60% were solid, the other 40% weren't. Our lobe distribution was as you'd expect, with roughly a third of those nodules being in the lower lobes. And you could see in terms of the lung region distribution, 13% of our nodules were pleural-based. Again, these are sometimes super challenging types of nodules when they're pleural-based, but a good proportion of them were pleural-based. We had an average sweep or a DT spin of about 2 per case, and our average radiation time was under 4 minutes and really super low doses of 26.7 milligray. So it's a 60-degree spin. So your radiation dose is much less compared to when you're doing full cone beam spins, which are more or less 180 degrees, a little bit more radiation. We also attenuate our dose. Our diagnostic yield using strict definitions was 90%. The malignancy prevalence in our cohort was around 75%. And with the diagnostic accuracy of 95%, we were able to follow most of our patients out 6 months. And this tool and lesion was achieved at 98%. So, we had really good success with actually doing what the technology set out to do, which is to get you to a nodule and get a tool in the lesion. Of the 12 non-diagnostics, 8 had follow-up availables, and only 1 was false negative for cancer. So if we could show tool and lesion, we were pretty confident, and didn't get a malignant diagnosis. We were pretty confident that was ultimately going to turn out to be a benign nodule. If you look at our subgroup distribution, there was no differences in diagnostic yield in any quartile or tertiles of however you distributed the size of these nodules. So the diagnostic yield is the same in sub-centimeter nodules as it was in larger nodules. So just to kind of go through this just a little bit, I think that our diagnostic yield was very comparable to other robotic studies in other robotic platforms that were done with imaging. So again, the imaging, I think, is what's super important here. If you look at our tool-in-lesion of 98%, I think tool-in-lesion is super important. If you could show that you delivered a tool exactly to where that nodule is, and that tool was in that nodule doing that biopsy, you are pretty comfortable that you're getting a good biopsy. And this has been shown in other studies. Brian Husta showed this, that if you could have tool-in-lesion, that your yield is far superior to instances where obviously you weren't in lesion. It makes a lot of sense when you think about it intuitively. If you look at our subgroup distribution, our mean nodule size was 13 millimeters, which was much smaller than what we saw in other studies. So I think that the power of targeting, the power of augmented fluoro, the power of imaging, when added on to robotic bronchoscopy, could really drive yields pretty high, even in smaller nodules. So I think the strengths here are that these were consecutive procedures for us. We didn't cherry pick. We got the referral. If we thought it needed a bronch, we did it. It wasn't just one operator doing it. We had 4 operators doing this. 2 of our operators were kind of new to the technology. 1 was right out of fellowship, so we can't say it's because you have super duper experience you can't reproduce this anywhere else. I think our personnel kind of speak against that. It was a large cohort. It was over 100 patients. Again, our diagnostic yield wasn't impacted by nodule size, which I think speaks more to the technology and use of available technology than it does to anything else. Again, it was a single center, and we're going to have to see how this works out amongst multiple sites across. Very similar to perhaps what we did with Navigate, where we took single sites and then just did a multi-center trial prospectively. And I think we'll probably get around to that once this technology matures. We'll see where we go. So with that, I'm going to stop. I'm going to transition over to Bobby and have him take over from here.
All right, thanks, Joe. Appreciate it. Hello, everyone. Everyone can see me. All right, perfect. So, first things first, I just want to thank Joe for talking about his experience and kind of really setting me up for success here for talking about the technology itself, and not only the data, but really how it works and how it's impacted what we do on a daily basis. So, I'm Bobby Mahajan. So these are my disclosures. So today, really want to talk about is a lot of what Joe talked about from a data standpoint, but not only to show that that we are not only looking at the standpoint of improving yields, and that's what really we've been looking for decades, but the importance of adding advanced imaging. Now, when we add advanced imaging to any bronchoscopic platform, we know that we get an improvement in diagnostic yields. I mean, that's a given. I think that, really what we have to focus on, and what we didn't focus on as much as we could have in the last 2 decades, was not improving the tools necessarily, not improving the way we get out there. It really is improving the diagnostic imaging and trying to make that advanced imaging as available as possible. The goal is to democratize advanced imaging, so it doesn't have to be when you have a cone beam CT. It doesn't have to be when you have anything mobile. It really, you want it to be able to be an option with a regular C-arm, and that's what you end up seeing with doing Tomo with Galaxy, to actually get a 2D rendition into 3D and ensure that your needle is in the lesion. So again, I know Joe showed this earlier, but really what it does come down to is we can add advanced imaging. We're going to do better for our patients. We're going to get a better diagnostic yield, and frankly, based on the imaging, we can go after smaller lesions and again try and show what Joe emulated with a 14 millimeter, 13 millimeter median size, because we know where that nodule is in real time. So, if we talk about how we benefit from looking at a robotic platform and imaging, it really is pretty obvious or inherent in the sense that the goal is not just to look at the idea of using a robot to go after a a virtual target. Really, the goal is to take the data from any kind of imaging platform, whether it be cone beam CT or a regular GE, 9900, taking that data and putting it into the galaxy. And the way we really look at this is based on digital tomosynthesis. And I will say that digital tomosynthesis has been around for a long time. It's been used in breast imaging for decades. Really, we've only recently tried to adapt it into lung imaging over the last 7 to 8 years. And really what we look at is we're taking multiple images or projections on a spin of some kind of imaging platform, whether it be a cone beam or a regular fluoroscopy machine, and taking those individual projections and stacking them on top of each other. And as a result, you take 2D images, which you would normally see with a regular fluoroscopic image, and develop a 3D image by stacking them over one another and changing the density so you identify that image. As a result, when you've identified where that nodule is in real time, where compared to where it was with the CT was done in the setting of changes in ventilation, chest wall rigidity with anesthesia, you make up for that CT to body divergence. And that's really what you're doing with the Galaxy. You're integrating the imaging into the robotics. And the nice thing is looking at the fact that all of these different kind of modalities can be used with the Galaxy. I have an Azurian. We put that data into the Galaxy, a GE 9900, a CEOS. All of those can be used integrated to put data into the machine to update where the lesion is and use augmented fluoroscopy. But really, not only can you use this whatever imaging modality, but it's a very small footprint, especially in the setting of having very small bronch suites in the generalized kind of population of what we do on a regular basis. Now, I do want to talk about one thing in the sense that we all have very different types of workflows in our bronchoscopy suite. And again, this isn't to be I try to be agnostic in terms of the robotic platform, but really what you look at is in order to have robotics and some kind of advanced imaging, it really does change your workflow. So if you look at the flow chart for number one, a robot and looking at a mobile cone beam CT. So really when you look at these different types of approaches, it does change how you do things, how you actually integrate imaging into your robotic platform, and how your workflow changes with that. So for example, if we're looking about any other robot using with a mobile cone beam, you're doing the normal aspects with regards to uploading a CT, driving your camera out to the lesion, but then you have to stop, bring in your mobile cone beam, use a manual isocenter, do the 3D workflow, make sure there's a collision check, get out of the room. I hope you're getting out of the room if you're using it. Put that information into the robot, and then again, update your lesion and look for where that lesion is in the new kind of image and where you are in relation to the plane of that image. So really, it does change how you approach each patient and the amount of time you have. And really, data reliably shows that in order to have a financially sustainable bronch program, you have to be able to get through multiple procedures in a low direct cost approach, but also very efficiently. So really using this a mobile cone beam, while it might give you the data you're looking for, the workflow can be very challenging, especially in a time-strapped situation. Number two, even if you're looking at a robot with tomo-capable solution, meaning that you're using another form of tomo, it's very similar in the sense that you're loading that CT, you're driving out to that lesion, but then you have to use an additional type of technology to find out where that lesion is in real time and continuously use fluoro, adjust your scope, fluoro, adjust your scope in terms of obtaining the right plane for that lesion. And again, it isn't very efficient and it really isn't integrated. You're taking two different technologies and putting them together and hoping they work, okay? Really what you see with Galaxy and what we've seen in our suite is really that it really becomes relatively effortless in the sense that I can spin as many times as I need to find out where my lesion is, where my needle is in relation to the lesion. And in general, it all relates to one bed, one simple C-arm, and I can get the answers I need and confirm that I'm in the lesion. Now, the tomosynthesis is a great aspect of it, but really what the hidden capabilities are the augmented fluoro, meaning that just like you have in a cone beam CT, I actually have the augmented fluoro from my standard C-arm on my fluoro screen, and all I've got to do at that point is be very basic and try and get my needle into that circle. I confirm in 3 different planes that I'm in that circle because our augmented fluoro moves on the screen as I rotate RAO and LAO, and then I'm done with my procedure. It used to be very much that I would sit there and wait for my on-site pathologist to give me an answer. Now I do all my biopsies with needles, forceps, cryoprobe if necessary, and then I'm all done. I'm not waiting for obsessively with my radial probe or waiting for a call in the room. So one thing we also have to understand, and I think that we forget this, mainly because we're so entrenched in how our equipment works on a regular basis, is that one, we have to optimize the footprint. It's an incredibly small piece of equipment. It can be rotated to the top of the bed or to the side, but really it can be constructed in how your bronchoscopy suite works. And then the last part of this, which is really something that we're shifting to not only as a hospital in general, but as a profession, is trying to look towards things that do not have to be reprocessed. So the scope for the Galaxy is a one-time disposable scope. I put that scope on when I'm done with the procedure. My favorite part by all of my respiratory therapists in the procedure is to take that scope and throw it in the garbage. And the reason for that is not only because it reduces the risk of cross-contamination and damage to scopes, but also there's the processing that comes with that scope. So it takes on average about 76 minutes hands-on staff time to actually get that scope cleaned between procedures. And per processing, it takes about $114 to $280, and as many as 34 to 27 touches that occur during that reprocessing. Not only to mention the amount of I would say capital investment that is required to develop and do that processing, especially in a bronch suite that's been entrenched, and again, in using the typical Olympus washers. So really, you want to make sure that when we're looking at what's best for our patients, but also what's the most efficient and cost effective for us, we have to look at things that are, one, disposable, and secondly, things that do not require us to purchase new capital in order to do what we want to do with the expensive robots that we've already purchased. Now, I think this is a very big part of what we look at with regards to patient safety, but also staff safety with regards to minimizing radiation dose. So if you talk about what is the best for our patients, we obviously are looking out for that, but we also want to know what's best for our staff. And more recently, appropriately, we're looking at what the incidence of radiation exposure and how high a radiation dose we're exposed to, not only from the proceduralist, but also from the staff, respiratory therapist, and nurse. And the effective dose of chest examination with a tomosynthesis is less than 2% of the published averages of thoracic CT. So we're really bringing down that radiation dose, as Joe said. And frankly, we do most of our tomo spins and our follow-up imaging once the tomosynthesis has been done on a low dose CT, especially with pulse. So, not only the cross-contamination capabilities, but also the radiation dose that goes down significantly with an integrated platform of robotics and tomo is really what's safest for not only our patients, but also for us. Now, the thing that is really changing for us, and I think that, I believe that most of us as physicians have not been adequately kind of educated in how we talk to our not only administrators, but look at the financial sustainability of the procedures we do, is really understanding what the direct costs related to our procedures are. So the direct cost really is what we are paying in things like disposables, the room, the equipment for each procedure. That is a cost that is incurred to the procedure, and as a result, it cuts into the amount of margin you make on the procedure. Now, from my standpoint, it really does come down to, it should be what we're looking for, what's best for the patient, meaning having integrated imaging and a robotic platform is showing us that outcome. But we also have to answer to our administrators and show us that we are actually making this something that they're not losing significant amounts of money on. So really what we've seen is that only recently, the Galaxy bronchoscopes, depending on where you are, may qualify for transitional pass-through or a TPT code. And what this is that CMS awards a TPT payment status to facilitate Medicare beneficiaries access to new and innovative medical devices. And really what this is looking at for disposable bronchoscopes. So really what we end up seeing is that in certain Medicare patients, as of January 1st, 2024, when using a disposable scope for CMS patients, hospitals can apply for reimbursement for that scopes and get paid back for the scope being used, and that occurs for a 3-year period. Our institution themselves, using the HPCS code of C1601, has gained a significant amount of money back on our scopes, almost the entire cost of that scope back from CMS. And as a result, our administrators are very happy, not only that we're getting diagnoses on these patients and moving them through very efficiently, but the direct cost is lowered significantly for each procedure we do. And honestly, we're not losing money, we're actually making money on these procedures, which, as you guys know, is not always the norm for bronchoscopic procedures in IP. So I do want to show one case example, and this is a little bit different than what Joe showed, mostly because, you know, the tool-in-lesion is important, but it's also important when you don't see a tool-in-lesion. So this is a patient who I actually was at our Virginia Cancer Association meeting speaking, and a woman came up to me and said, look, I know I don't know you, but my mother, who's, you know, 75 years old, was told that she has a lung nodule that was 9 millimeters in her left upper lobe, and the only way for that the hospital in their area could get a diagnosis was to do surgery. And you know, unfortunately, she lived about 2.5 hours away from me, so I couldn't see the image. But I said, look, why don't you come in? I feel pretty comfortable we'll be able to get to this. Now, that does underlie the principle that, in general, I'm going after nodules that are much smaller than I would have gone after in the past with either Lumicite, Monarch, or Ion. So we brought this patient in. She drove those 3 hours, and it was a small 9 millimeter nodule close to the pleura with a ground glass opacity with some solid component, no bronchus sign. So we said we're going to be able to get to this. And mainly I was very comfortable saying we're going to get to this because with the Galaxy platform, what I've seen is that because I know where the image is, where the nodule is in real time, it just depends on how much work I want to put in to getting that to that nodule, meaning that I might navigate out to that nodule, do my spin, put a needle out, and if not exactly where I want, I'll spin again. So we can spin as many times as we need to actually make sure our needle is in the lesion. So I was able to get out to that nodule, put the needle out, and I'll show you a picture briefly, is that the needle actually went underneath the lesion. I could see that I wasn't in the right place and had to make an adjustment. So essentially, after that biopsy, it came out as adenocarcinoma. It was about a 45-minute procedure. There were no complications. I placed fiducials for SBRT, again, because she was not a good surgical candidate. This is the nodule. Again, you can see the solid component with some ground glass around it, a little bit of puckering of that pleura as well. And this is, you know, this is an image of the actual nodule when we navigate it out. Now, I want to point out a few things. One, you can see the nodule pretty clearly on the far left screen in terms of the tomo image. And again, this is a pretty normal image for us. This is not something cherry-picked at all. And then on the right, you can see the negative 45 and the positive 45-degree angles also seeing that image. So you know you've triangulated the nodule in 3 different planes. And then lastly, all the way to the left, you still have image availability in the actual bronchoscopic view. So if I'm worried about bleeding, if I'm worried about anything in terms of, you know, trying to injure tissue, I can see that. But even more so, I see my tool coming out and I'm able to puncture through the airway wall instead of just biopsying the airway without actually getting tissue. So this is the image I had. I adjusted and made that my new target. Now, the interesting thing is, you know, again, I put my needle out to get to that lesion, and you can see on this on the left panel that the nodule itself is here, and I actually went underneath the nodule. My needle missed, and this is really important to me, frankly, because we do talk quite a bit about tool-in-lesion, but it is very nice to know that when I put the needle out and I wasn't in the right place, I can readjust, retomo, and put my needle into where I need it to be. Okay. The next image, this is a really great image of the actual augmented fluoro. So you can see in the left plane, that is that circle which represents my nodule. Now, again, you're looking at a 2D image here, but you have a representation from the crosshairs of where the 3D lesion is in relation to my working channel. And all I really got to do at this point is put my forceps into that circle, confirm in 3 different planes that I'm in the right place with the circle, because my augmented fluoro moves in RAO and LAO, and I know that I have my biopsy. So I'm not sitting waiting for my my pathologist to confirm it. I can use a radial probe if I want to, but really after a while, every time I put that radio probe out into that augmented fluoro, I would be seeing an image. So I use it maybe 20% of the time. Previously, I was 100% of the time radial. I've got to confirm I'm in the right place before I'll take a biopsy. So in summary, really what we look at it is, 5 value propositions here. 1, you always have vision. Again, even when you're biopsying, even when you're putting a tool out, I know I'm puncturing through the airway, I'm looking at that lesion. Now, I will tell you, based on the data we did from the benefit trial, we really only saw about 30 or 40% of those lesions that are that have a bronchus sign are able to be seen bronchoscopically in the periphery. Yeah, you might see some changes in the actual airway, but very rarely are you just seeing a tumor right in the middle of the airway. So you want to have always on visualization when you're putting that needle out, putting that forceps out, to make sure you're not just biopsying air. The robotic solution with integrated tool and lesion confirmation. At the end of the day, everyone, that people who do peripheral bronchoscopy, one of the worst things you can do is do a biopsy. You get home 5 hours later, you're laying in bed, you're like, oh man, I just hope I was in the right place. That's what I do. I don't know. I don't advise it for everyone. But really, the ability to know that your needle was in the right place and that you are not going to get a false negative really is comforting, not only for you, but obviously the patient. The risk of cross-contamination is eliminated, mainly because we throw that scope away right after the procedure. And again, you're not worrying about the reprocessing of these. 4th, again, the TPT code really has been a huge boon for us, in the sense of, the fact is, I'm not paying for reprocessing scopes, not having to reuse them. But when I use a disposable scope, I have the ability to actually be reimbursed, because it is a new technology, because it is a better technology. And frankly, the group of CMS admin is trying to promote these type of technologies because they are better. And then finally, it's a small footprint. We move this all over the place. Yesterday, my partner Priya Patel took this over to the OR, did a case there, and then we brought it back over to our bronch suite and did it in the bronch suite. So the fact that it is small, it is compact enough to fit in the smallest of bronch suites, but still be mobile enough to be used throughout the hospital, really does make this a much more robust and dynamic machine than we're seeing in any other platform across the country. So with that, I'm going to leave questions, but I'll also put both Joe's email up and my email up. Feel free to contact us if you have any questions, either about the technology, about how we've adapted to the technology, or if you just want to talk about anything. Again, feel free to talk to us anytime. Thank you very much.
Thank you so much, Dr. Cicenia and Dr. Mahajan. Very comprehensive review for such an exciting and amazing technology. So we have a couple questions came out. I encourage the audience, if they have any questions, to submit them in the chat box, and we'll be happy to answer them if we have enough time. So the first question we have is, with having used different technologies, what has your experience been with adapting the Galaxy solution with regard to staff training, tech adoption, etc.? I think this is towards Dr. Cicenia, but I mean, either can answer on that.
Sure. Oh, you're muted, Joe.
Muted.
Let's do it. There we go. Thanks, Emily.
Yeah.
So here's the thing. My at our main campus, we have an Ion and Monarch and Lumisite. And when we started our nodule program at one of our regional sites, I had to get a robotic scope there. So because I didn't have an imaging solution there that was acceptable to me, meaning that I didn't have mobile cone beam or fixed cone beam, I elected to push for the Galaxy because all I had there was 2D fluoro. And so I pushed for that, I got it, and I was able to train my nurses, I was able to train my radiology techs, and it was pretty facile to get it started, get it running. And the workflow, as far, you saw Bobby's list of those workflows. They looked, long, and I guess the people who do a lot of the same thing will probably say, yeah, that's a long workflow, but it happens quickly. But I will say, having used a lot of these monarchs and illumocytes and ion with the Cios integration and Galaxy, the Galaxy workflow is, for lack of a better word, very compact. So everything happens from where I'm standing. So everything's on my touchscreen, which is right next to me. The spins, or the tool-in-lesion, or we call them tilts, tool-in-lesion tomography, right? That's done right from where I'm standing. All my radiology tech has to do is spin that in 60 degrees. And so everything is compact. It happens very quickly. After I do my spin, it takes about 15 seconds for the imaging to be processed and pop up. I mark where the nodule is. I mark where the tip of my scope is, and then within another 25 or 30 seconds of processing time, I get my targeting screen. So literally within about a minute and a half, and we'll say a minute 45 because of the 15-second spin, under 2 minutes, I have everything I need to complete my biopsy, my targeting, my augmented fluoro, and my location updating. So again, very, very compact. I don't have to do a collision check. I don't have to walk away and come back. So for me and my staff, it's really convenient. It's very easy to do. And, am I sad when I have to go to the main campus and do a little bit larger, non-compact kind of workflow with the ion? No, but I do miss the augmented fluoro. I like Bobby's metaphor of close your eyes and hope, or why bother using fluoro? You don't have augmented fluoro. So I have gotten used to it, and I miss it when I don't have it. But I think this was asked of me at CHEST, last week as well. I think, do I favor any robot? No, I think that a robot with an imaging solution is what's important. As far as I go, I think I like the compactness of the Galaxy and the ability to do everything right where I am, very quickly, very accurately. I'll kind of leave it at that.
Awesome. So speaking about the imaging augmentation, I think the question is for both speakers. What adjunct imaging technologies are you using with the Galaxy at the moment, if you're using it?
Yeah, so I can speak to that. So we've had a lot of imaging options in the last 3-4 years for us. So we actually do our Galaxy cases, and we integrate it with our cone beam machine. So we have an Azurian, but it's more of a backup for me now. So for example, today we had a case of a 2-centimeter posterior in the lower lobe on the pleura, and I have that cone beam option if I need it, but very rarely am I having to use it on a regular basis. We do our tilt with our cone beam, and if I see a great image, which is 98% of the time, I'll use my tool in, I'll take a biopsy, and I'll be done. But if I'm looking at a oligometastatic disease with a 6-millimeter nodule, there might be times where I'm using that tilt to get as close as possible, and I still can confirm if I need to with a cone beam, but it's pretty rare. So I joke that we convinced our hospital to put this cone beam in 2018 when they were building our bronch suite, before we had access to actually good tomosynthesis. So I think that adjuncts are great. We will use radial as well as necessary, but I still remember this at the end of the day it must have been CHEST 2019 or 18, and I was sitting next to Joe. We were watching one of these robotic talks, and they were talking about cone beam integration, and Joe just kind of leaned over and said, "What's the common denominator for all this? It's all the imaging." Right? So if we can look at really focusing on how we develop imaging here, regardless of what you have, whether it's a Cios, a cone beam, a 9900, then you know you're going to get your best yield. So I think that when people have additional imaging capabilities, it's great, but it's not always necessary anymore. And honestly, it becomes a workflow issue more for me. Just like Joe, I like to get in there, do my tilt, know I'm in the right place, take my biopsies, and move forward.
Yeah, I haven't really had a need to use radial EBUS because when you have the targeting and when you have the augmented fluoro and you put a needle out into that blue ball, which is exactly where you located that not 2 minutes ago, and then you spin into a 30 degrees out into a different plane, and you're still in that ball. I don't know why you would even need a radial ultrasound. It doesn't add anything, because what you're looking for is tool in the lesion. You put a radial ultrasound out, you still have to pull it out and put your tool in. If your tool goes out, you could show that your tool is in the lesion. I don't think you need anything extra. I think so. I don't use anything beyond what I get with my tilt spins. And sometimes I don't even do a tool and lesion. I mean, if I'm in that blue ball, I'm in the blue ball. I don't waste time doing the tool and lesion.
Well, I think that even though you're not doing the tool and lesion, what I do, Joe, and I think the same with you, is that I will make sure that in 3 planes that I have the tool in the lesion, because the augmented fluoro will follow an RAO and LAO. And it's the exact same thing as me using a cone beam and looking with their augmented fluoro. So frankly, it's a workflow issue, but at the end of the day also, again, don't get me wrong, there's 30, 35 cone beams out there where people are using them on a regular basis. At the end of the day, we want to be able to offer this kind of technology to everyone who has, a regular fluoro machine, not necessarily the highest end, and still get advanced imaging as opposed to just regular imaging.
Okay, excellent. We have another question. Can you share more about what instruments can work with the Galaxy scope?
So
any instrument that you've been using all along, we have a variety of needles, variety of forceps, triple brushes, really, the 1.1 cryoprobe. I mean, whatever you want to put through it, you could put through it.
Yeah, it's tool agnostic. So yeah, like Joe said, I use Olympus forceps, a Super D needle, and I can use an Irby cryoprobe if I want a 1.1, but it really doesn't matter what the tool is or who makes it. It can be used down that working channel.
Okay, excellent. I think that's a little bit more of a complicated question. What is your advice on how to approach purchasing directors when making a decision to acquire new technology? What should the key talking points, areas of discussion be? And I guess I think the question is more of when you're trying to purchase a navigational platform, what are the points that you're bringing on to kind of sway them one way or another, or I guess pitch to what you want to get,
Joe, you want to go first? You want me to go first?
I mean, sure, because I went through this, look, I think that it depends where you're. I think most hospitals, are looking at cost. They're looking at cost and value, and so the big thing that I had is they were willing to pay for a robot, but they weren't willing to pay for a robot and a mobile cone beam. The two of them together was really cost prohibitive. And yeah, I could have offset the cost of a robot by having a placement deal, those 6-month placement deals, but after 6 months, then what do I got, right? So there was that. So the startup cost was a little bit lower here because I could incorporate whatever 2D fluoro I already had laying around. Now, if you have a SIOS or a 3D OEC laying around, maybe that changes things a little bit. But then the other thing that kind of flipped the curve was also the TPT reimbursement. So if your scope is, whatever, I don't want to get into too much into TPT, but TPT pretty much reimburses you for about 90–95% of the scope. TPT is not going to last forever. It's going to last for another 1.5 years. But again, on a per cost, understanding what the reimbursement is going to be, and the reimbursement is going to be for Medicare patients is APC 5155. It's going to pay somewhere around $6,200–$6,300 depending on where you are in the United States, as long as you do a needle a needle biopsy and a forceps, you're going to get 5155. So knowing what the reimbursement is, and knowing what the cost per procedure is, and knowing that the cost offset is going to be about $1,400 on TPT per case, it made the per case contribution margin really explode, and they like that too. So, you know, I think it's really getting in, talking with your C-suite, talking with your financial people, seeing what equipment you have, and seeing what they're looking for. Some places want to do purchases. They don't want to do rental deals. Maybe they don't want to do placement deals. So it really varies where you are, and you have to talk with your financial people. That's the best advice that I could give.
Yeah, no, I would echo most of what Joe said, and I would even go further to say, I mean, I think there's two aspects of kind of not only justifying but advocating for what we do. I think that most of the times we as, again, physicians aren't really that versed in the actual economics of what we do or the medicine that we practice. But one part of the understanding is using these financial, not only vocabularies, but understanding the principles behind it to get what your patients need, right? The idea of just stomping your feet and saying, I want this type of piece of equipment, it just doesn't happen for us anymore. And part of that is because the contribution margin, which is what we get reimbursed minus the actual cost of each procedure, is not very high compared to other procedures like a thoracic surgery or a lobe. So when you're not making a lot of money on each procedure, you have to be able to show what the benefits are. And I had an administrator tell me once is that if you come to me with a piece of equipment that allows you to either do more procedures or do it at a lower cost, I can support that. And honestly, we see that with both ways with the Galaxy. That what made it pretty easy. One, we're more efficient because I'm not having to step out of the room. I'm not having to get other equipment. And we do cases faster. And two, is cheaper, not only because of the TPT, like Joe said, but also I didn't have to buy a new piece of equipment. It was already in there for us, right? But those really do matter. So when you look at the idea of, you know, what should you get? And I think it's a great question. How do you talk to your administrators? One, you have to be able to talk to your finance people first and make them understand the space. At the end of the day, if we can do better for our patients by diagnosing nodules earlier, getting them to earlier stage resections, patients are going to do better, but the hospital is going to make money on that, and you can be the facilitator of that. The second aspect, which I think is just as important, but is, you know, I think more essential for what we do on a regular basis, is that, you know, when we try to justify what we do, it can be a situation that if you feel more confident that you're going to get a diagnosis going after a nodule and having it be positive, you're impacting what that hospital's bottom line is, right? And that's what they care about at the end of the day. So when we have a patient that has a 1 centimeter nodule, and I feel very comfortable we're going to get it, it isn't me saying, well, let's bring you back in 6 months and see if I can get to it. I'm going to biopsy it now. Now, along the flip side of that is, don't get me wrong, guys. I think that the Galaxy is the best option for us, but also whatever you have is usually the best option, meaning that if you already have a CEOS in your hospital, it really doesn't matter what you get because you're going to be able to integrate that in some way. Might be a little clunky, but you're going to be able to integrate that into whatever platform you get. The goal is to make this as seamless as possible and use what you already have, as opposed to having to go out and buy something new, because of the fact that every time you buy something new, that goes in for the direct cost or the actual cost of your procedure. And at the end of the day, 2 years later, when you review your data with your administrators, you don't want them to say, well, we bought you all this equipment, what am I seeing for it? You want to be able to tell them, I was able to do all of this, build this, get you more resections for earlier stages at a minimal cost compared to what we could have done with other equipment. Complex question, you're right.
Yeah. I have a question on my own, and listening to both of you talk about the technology, I think to myself, what does the learning curve look like for an advanced user? And also if you had observed it in somebody who's a bit more naive for navigation, is that something, you know, someone who wants to start a program who doesn't have a lot of experience with robotic bronchoscopy, is that going to be challenging? Does he need to do an extra fellowship, or there is some more of an, you know, friendly user kind of interface? And the other question is kind of the other end of the spectrum, very experienced user who is trying to, you know, high volume, right? Did you notice that difference in the overall of number of cases that you could fit in your 1-day block using, you know, the Galaxy versus other platform, considering that you're not having to spin and get out of the room, and did that actually translate into more procedures per day? Because I guess to your point, that can be something that is heavily arguable for such a technology in when you talk to administration, because to them that equals one more patient, one more case, one more anesthesia, and so on and so on.
Well, Joe, I'll talk about the inexperienced. You want to talk to more experienced? So I will say for inexperienced, not that you're that much more, not from an age standpoint, dude, but with the way I look at this is, you know, it's a great question in the terms of, have you done tomo before or not? So I was a very big Illumisite user, frankly, because the other robotic platforms didn't have imaging until recently. And when it comes to tomos, it takes, you know, 15 to 20 kind of spins with Illumisite to get used to that tomo. Because we didn't have a huge learning curve for robotics, because our staff already knew tomo, it was really nothing. It was very little change. And frankly, I had used the Monarch and the Ion. I think that, you know, because of the fact that a robotic platform kind of integrates the stability, but also the imaging it was what makes up for the fact that the learning curve is not terribly long. And the reason I say that is, and you know, not to go into too much detail, but the workflow of what you're doing with a Galaxy is very different from the traditional workflow that we focused on. So if you think, and Joe might talk about this, if you think about what we've done for the last 15, 20 years, what has it been? Is get as close to that target as possible, the virtual target, and then try and biopsy everywhere, because the closer you are to that target, you might have less deflection, you might get the answer. Instead, with what we do with Galaxy is I navigate out. When I get to within 4 centimeters of the lesion, I stop. Driving the robot is about 10% of the procedure out to the lesion. I do my tomo, and now I have an image-guided target of where my lesion is, and then I can do whatever I want to get to that lesion, and the robot will tell me what direction to go to. So when you have an image and you know where you're going to go, the learning curve is pretty straightforward, because you have the ability to do it however you want. We have you know, other people that we know use the Galaxy will do a breath hold the whole time when they're navigating out to biopsy. We have some people who will not use a breath hold. We have some people who don't follow the line at all, because the traditional line, and that's because we know where the image is and we can get out to that image. So the learning curve, you know, is honestly about, I would say, 10 cases where you feel really comfortable. But as you see from the yields, it isn't like the first 10 are poor yields and then they get better. It's more of a question of how do you develop your actual workflow and how do you want to approach it? Because when you have the nodule as a, you know, dedicated and objective location, you can do it however you want. It's just questions of how you want to develop your own approach to these nodules. So Joe, I think that, I don't know if you feel the same way, but
yeah, I mean, the user interface is a pretty simple user interface, and it's really scalable to anyone. I think that the learning curve is solely in getting used to an Xbox controller for the most part. Once you get nimble with that, and it's not hard to get nimble with that. So whatever the learning curve is for that, if you've used an Xbox controller before, if you're a gamer, or if you've used Monarch, or you know, you're going to pick this up pretty quickly. The thing that I want to point out here is that as Bobby was saying, once you get into the targeting mode, right, and you saw this right on my slides where there's a ball and there's a ball and a bullseye, and you know, the Ion integration is similar to this too, where you kind of have this ball and bullseye, right? As soon as you understand where that target is, it is telling you, the machine is literally telling you which way to turn, which way to get your controller to, you know, go to get you lined up to the center. And then once you have that, then you just shift over to your augmented fluoro screen when you're putting your biopsy tool out. Now this whole process reduces the mental load incredibly, So you know how people say it's easy to do one thing at once. It's harder to do two things at once. It's impossible for your brain to do three things in the background at once. So this really dumbs it down to only doing one thing at once, whereas a lot of other technologies still require you to do two things at once. Try to figure out which way to go to kind of get your target where you need to go, and then put a tool out and then interpret fluoroscopy. So the mental workload, right? The brain workload is really diminished with this, which I think really impacts the speed of the learning curve and the scalability of the product. So the controller is a little bit different than a trackball. Trackball might be a little bit more of a natural movement for people to pick up. But like I said, I've had 4 or 5 different users. I've done some sim center stuff with some folks. It's not that hard to pick up if you're used to doing a NAPRUNC before. So, and as an advanced user, once you've mastered those things already, there's some other master type of tricks and stuff that you could use if in fact you need it. I mean, look, we have all these robotics, we have all this targeting, but there's still really difficult nodules and difficult regions. Central middle third nodules still incredibly difficult, regardless of what you got. Ones down in the crotch of the lower lobes and the medial basal segments, really sometimes could be difficult. But posterior segments could be difficult. But you'll figure these things out as you go along because it's easy to master the basics. If that makes any sense.
Excellent. Well, thank you so much, Dr. Mahajan, Dr. Cicenia. We appreciate you coming in on our Society Advanced Bronchoscopy platform. And everyone, have a good evening.
Yeah, thank you so much. We appreciate it.
Yeah,
Thanks.
thank you again, both of you, for a very informative presentation. And we want to thank Noah Medical again for being our sponsors and supporting the SAB. Everyone, thanks for joining, and we look forward to seeing you all at more webinar events. Thank you and have a great evening.
All right.